ahead of us for today's meeting. We have an interesting guest who is going to speak to us and maybe educate us more on global health security. So my name is Dr. Pamela Godia. I am a lecturer at the Department of Public and Global Health. Previously, we were a School of Public Health, but we are still in the area of public health. So welcome so much to this webinar today. Our topic today is the role of schools of public health in the changing health security architecture. We know there's a lot of things that have changed in the recent past. A lot of shift of policies, especially being informed by COVID-19 and how prepared we are to handle emergencies. So our speaker today is going to be Dr. Ahmed Aguel. He's a long-term colleague and long-term schoolmate here at the Department of Public and Global Health. Dr. Aguel has been appointed as the Vice President of Global Health Strategies at the UN Foundation. So congratulations so much, Dr. Aguel, and we are happy for you. He is the immediate former Deputy Director General of Africa CDC, and he has over 3 decades of experience in public health, planning, health policy, and global health diplomacy. So Aguel has also been the inaugural Deputy Director of the Africa CDC. It's a position he had since in 2019 and has led the COVID response pandemic, as well as steering the institution to be autonomous within the African Union. Previously, he held distinguished senior positions with the WHO, both in Geneva and the Regional Office for Africa, as well as being the head of international health relations at the Ministry of Health in Kenya. So Aguel is an alumni of our university, University of Nairobi, and also the Center for International Health at the University of Bergen in Norway. So Dr. Aguel, you are welcome. I know you have a presentation to make, so if you are ready, you are able to make your presentation. The floor is open for you.
Thank you. Thank you very much, Pamela, and good morning, good afternoon, good evening, whatever it is that we are joining from. I'll share my screen. Yes, thank you very much. I'll share my screen.
Yes.
Right now?
Yeah, share right now. Yes, you're able to share. Should be fine so that we begin the session.
Okay, that's fine. Let me do that.
Okay.
Health after many, many years. And I'm honored really to speak with all of us today, this afternoon, on a topic that I think is not spoken about enough. Maybe because within the larger public health space, we are so busy doing other relatively urgent issues. I am convinced that the more we bring our specialized institutions into the space of strategizing, preventing, thinking about how to address our public health challenges on the continent, the more we are going to secure this continent in a very successful way. So today I would like to speak about the roles of schools of public health when it comes to health security architecture globally. I'll divide my presentation into these 3 main areas. I'll speak a little bit about both health security and schools of public health. I'll delve into the context of why health security and why the schools of public health. And then I will speak also at the end about the opportunities that exist for schools of public health to exert their influence a lot more than they are doing right now. This I believe in very strongly, that we on the continent, our true wealth still remains our people. And for us to be able to exploit this wealth, who are our people, then our schools, including schools of public health, our schools on the continent must provide that platform for us to grow our indigenous knowledge and turn that knowledge into solutions that we can be able to utilize here on the continent. And I'm happy to be quoted that our wealth is our people, and our schools must provide that platform for our indigenous knowledge to be grown into actual solutions that we need on the continent. So the School of Public Health, I know the name has changed a bit, but the School of Public Health here at the university, and Pam, I will challenge you and the rest of the faculty that you probably need to start thinking about designing a beautiful logo for the school and make that available to us online when we are searching for you. But what we do at schools of public health is we learn how the conditions, and this is not a definition for academic purposes, it's a definition for purposes of action on the ground. We learn how the conditions in whichever places where we live, learn, grow, etc., how those conditions actually affect our health outcomes. This is the core of what we do in schools of public health. But as we do that, we also learn how different professionals, and I'm deliberately stepping away from health professionals only. It is how all professionals actually collaborate to build interventions that will address the challenges that our conditions give us when it comes to poor health outcomes. So we not only learn about those conditions and how we can be able to improve on them, but we also learn how to work together as different professionals beyond the health sector. When these two very key learnings happen, then we get to a space where public health can be able to play its rightful role in improving society. But what about health security? WHO has this very beautiful publication on health systems for health security. And today, I put it to you that we need to step away from just health systems, and we need to get into the mode of thinking about systems in general, whether they're agricultural systems, whether they're water systems, whether they're security systems, what engineering, whichever system can be able to impact our health security. In fact, if you reflect back on your day-to-day life, any sector of society that fails, it becomes a health problem. And if it is large enough, it becomes a public health problem. Whether it is our engineers who have not built good roads, the outcome becomes one that is a health problem. If it is our agriculturists who have stored our food badly, it becomes a health problem. If it is the security colleagues who have not protected certain areas properly, it becomes a health problem. So let's think about systems and not just health systems. Let's think about systems for health security. And these are usually those actions that we take to prevent and respond to any disease threat or health emergency. Often, what hits the news are only the acute disease threats. You know, when you have Marburg virus outbreak, when you have flu, like what is rotating around the country today, whether you have COVID, measles, polio, etc., those are acute. But then those that tend to be a little bit more chronic, diabetes, in physical inactivity, bad diet, those are usually not classified as health security, but they really are, because in the long term, they will threaten our health, our enjoyment of our health. But all those actions that we need to take to prevent or to respond to disease threats and health emergencies, these constitute the systems for health security. But it is also very important to note that these activities are usually crossing borders. These activities usually involve beyond one community. And to be able to mitigate these public health incidents across communities and across borders, we'll need that we go into the realm of international relations. It will need that we go into the space of sovereign security, where one country will protect its borders quite aggressively. It means, therefore, that health security is not just about disease. It's not just about prevention and response to health emergencies. It is also about interpersonal engagement and relations. It is also about the security of our country. It is also about the social stability across the areas that will have been affected. So health security can be looked at as broadly as that. Now, let me also suggest to you that as schools of public health, we do quite a number of things, but these three for me are the ones that are key to the discussion we want to have today. A school of public health must have an effort of up to 75% focused on workforce development for health. And when a school is focused on building capacity of both health and non-health experts, whose capacity is aimed at securing the health of that particular community, that particular country, then that school is hitting a very important target, meaning that its primary focus is workforce development, and not just for health. It is workforce development for all sectors, so that those sectors can do the right thing and reduce the risks that we have within the health sector. A school of public health should also be doing research. Often, this is where we fail the most as schools of public health. We don't do enough research. Often, we wait for our students to write their theses. They do some very small research methodology focused theses and collect data here and there, but it's not active research. If a school of public health is not spending at least 50% of its effort in doing research, then they cannot be actively generating evidence that will be used in decision making. And you want to be a school of public health that actually actively generates evidence for policy to be relevant to that particular community. Thirdly, a key output for me for schools of public health is priority setting, particularly for health. And this is where a school will bring its expertise for its faculty, for its students, for its collaborators. They will bring all this expertise to be able to strengthen a community's or a country's planning and implementation of health programs. If a school is not part and parcel of priority setting for health, then the other two outputs, research and workforce, will never be complete, because workforce development must be context specific. You want to be training and producing a workforce for health that is relevant to your situation. You want to be doing research that is contemporary to the problems that your country, your community is facing. So although research is not as prominent in the school's outputs as, although priority setting is not as prominent as the other two, research and workforce development, nevertheless, it must be linked to those two so that what you're doing is actually contributing towards policy implementation and improvement in the health status of your community or your country. So this is from me: 75% workforce development output, 50% for research, and 25% supporting priority setting and implementation in a particular country. Let's shift now to health security and the role that schools of public health would have. Many times we don't reflect on just how much this continent is hit by disease threats and health emergencies. Last year, 2023, we had over 160 160 significant events across the continent. And these events, these public health events are always either a health emergency fully blown, like cholera, Marburg, Ebola, etc., or they will be disease threat or disease outbreaks that are quickly controlled. But when you look at history, where we were documenting the different significant outbreaks on the continent, you will see that every 10 years there is one big thing that was happening on the continent. But we have seen a change since the 2020s. It is not just one. We had COVID, which was global, but again within 2020s we had Marburg, which ravaged the central part of the continent. We have had Ebola, again, which crossed from the eastern part into, from the central part to the eastern part of the continent. We currently have cholera that is really, really disruptive, particularly in the southern part of Africa. The message here is there is always outbreaks on the continent of Africa. Our health security is constantly being challenged, and our capacity to respond is being stretched. It means that we need to be building appropriate capacity to ensure that as these challenges come, as disease threats visit our borders, as health emergencies break out in our communities, we are prepared. And this is where our schools of public health become very, very important. But they are important in the context of the global health security architecture. And the architecture keeps on shifting, but it is guided by these four big blocks. One are the instruments that actually guide the way in which we work. And these instruments, we see them in different fashions, different forms, different presentations. We have treaties, some of which are global, some are regional. We have decisions by our different collection of countries. We have strategies that are developed particularly by technical institutions and then given political life and approval. We have frameworks that guide the way in which we respond to specific disease threats and health emergencies on the continent. But all these instruments are only as good as the institutions that actually pass them. These instruments are only as good as the institutions that are going to implement them. And these instruments are only as good as the effect that they're going to have on the health security of a community, a country, a region, or the world. But this is a very important part of the health security architecture. And let's bear this in mind as we discuss the role of our schools of public health. And when I say schools of public health, I don't mean the classical school of public health. I really mean whichever institution is responsible for training of those professionals that are going to be part and parcel of preventing and responding to disease threats and health emergencies within a country or a community or a region. So instruments are there, a very important part of the health security architecture. Secondly, are the institutions, usually governmental, usually. And these institutions will organize themselves into global level organizations. You have the WHO, you have the UN General Assembly, for example, you have the WHO, you have the World Trade Organization, a very important institution, by the way, for health, just that we don't engage with it as much as we should. Apart from that, we have others, the World Intellectual Property Organization, at the global level, that is, and others. At the regional level, whether the region is defined as a continent like Africa or is defined as a group of countries like the EU, these regional institutions are also very crucial because they tend to be more active in implementation. When you have something passed globally, by the time it gets implemented at country level, it takes quite some time. While if a smaller group of countries, for example, the East African Community or the Southern Africa Development Community, when that smaller group decide on something, you find the implementation often is a little bit faster because of context being more relevant to these smaller groupings. So whether the institutions are global or they are regional, like in our case, the Africa Union, Africa CDC, or sub-regional, like the East African Community, the Economic Community of West Africa, etc., etc., or some are multi-country. A good example will be COMESA, which is essentially trade, but within trade, there are very important components that will affect our public health. They don't need to be countries that are bordering each other. They just come together for certain interests that they may be able to have. Institutions can be also at national level. Those that provide support to a country's generation of evidence. Cambridge is a good example, to a country's implementation of health security policies. I think Kenya still doesn't have a Kenya CDC, but I'm informed that is coming along. These institutions, whether global, regional, multi-country, or national, are extremely, extremely key to how the instruments we talked about are implemented and the effect that they have in that particular jurisdiction, whether it is a country or multiple countries being put together. So that is another very important component of the health security architecture, institutions. And let's bear these in mind as we think of the role that we can play as schools of public health. Thirdly, are the non-state actors. These are, like civil society organizations, philanthropies, the private sector, etc., etc. Those that will bring a contribution without coming through the government. They come through their own interest angles. These are very, very important, and today they drive a very important part of success or otherwise of the health security architecture globally. You have seen how philanthropies are playing very key roles in when it comes to health security. The Gates Foundation, MasterCard Foundation, Rockefeller Foundation, etc., etc. They play a very big role when it comes to matters of health security. You've seen how civil society organizations have been very active in providing expert support, providing a voice, giving advocacy platforms so that some of these instruments can either be passed in a way that will be beneficial to health security, or those that have been passed can be implemented, again, in a way that benefits humanity in general and a community if it was specific. The private sector, who trade within societies and communities, have become very important players, because when there is health security, they can be able to trade easily. When there is no health security, they can't be able to trade easily. The other side of the coin is also important, that some of the tools that and the products that we trade in when it comes to health will require investment. Whether it is vaccines, whether it is therapeutics, whether it is diagnostics, whether it is non-pharmaceutical products, they require some investment from the private sector, and they want to protect that investment so they can continue to make money from it. And this always has challenges, as we saw during the COVID season, with vaccines not being accessible by our less resourced countries, particularly here on the continent of Africa. And the private sector played its role in either making that more challenging or making that easier for countries that did not have enough resources. So the non-state actors are a very, very important player when it comes to the health security architecture. Finally, are the member states, the individual countries who are sovereign in nature. This is where things succeed or don't succeed, because that is where all the implementation happens. It doesn't matter which instruments you may have. It doesn't matter which supranational institutions, whether governmental or non-governmental, you will have. It doesn't matter what kind of support the non-state actors are providing. If things are not organized to be delivered at country level, then you don't get success. If they are organized to be delivered at country level, then you get success. And that is why it is very key and important for us to ensure that at the member state level, and that's where the School of Public Health becomes very important, because you are national in nature. At the member state level, there is good understanding of policy making, there's good understanding of implementation, review, and adjustment of those policies if they may not be working as efficiently as they were designed. So when you look at the global health security architecture, these 4 big blocks are very important for us to bear in mind. Now, the continent has struggled, as we saw from the 50s when we started documenting the different health emergencies and disease threats. The continent has struggled for a long time, and in the last 4 or so years, there has been from the Africa Union platform a call for a new public health order. And this is very important for our schools of public health to bear in mind as you plan and design your role, and I will propose a few areas in the coming slides. The new public health order is really a roadmap. It is a roadmap of how we, as resource-poor countries, can achieve sustainable health outcomes. How we, as resource-poor countries, can be able to also have health security. And how we, as resource-poor countries, can be able to play our rightful role as part of the whole global health security architecture, and not as recipients of aid and some donations here and there. The new public health order was, it's a vision that started way back in 2017. In late 2019, around the same time as the world was struggling with the COVID, the first cases of COVID-19, we expanded the conversation around this new public health order. It is based on experiences that the continent has gone through. And when the pandemic hit, we expanded our call to the world that we need a new public health order if we are to secure the whole globe as well. It has 5 pillars. The first is that we need strong African institutions for health. And I'm not talking about health institutions, I'm talking about African institutions for health. So where we need our planners to have strong institutions that contribute to health, they should have it. Our lawyers, our engineers, but also we need strong health institutions that are going to coordinate other institutions in providing a good policy framework and eventually delivery of these to the communities. These strong African institutions are the ones that will drive our priorities on the continent. These strong institutions are the ones that are going to ensure that when the conversation is going on at global health governance level, then Africa's priorities have been secured and they are part of the global conversation and resourcing. So strong African institutions is not an option. In fact, we saw during the COVID pandemic that countries that had institutions designed specifically for health emergencies, like National Public Health Institutes or national CDCs, they had a better response. They had a more organized approach than countries who did not have this as a separate standalone institution. It is an experience and a lesson that we need to strongly advise our governments that it is time for those standalone, strong African institutions for health to be present in each and every country. This is the first pillar. Second is workforce. Strengthen workforce for public health. This is where we train the right experts. We train, we give them the right training. We train them in optimal numbers, and then we give them the right tools. In this way, if there is a disease threat, if there is an outbreak, if there is a health emergency somewhere, then we can deploy these experts quickly to arrest the problem before it becomes a big public health emergency. And these strengthened workforce includes our community health workers. We need to start adjusting ourselves away from the model of getting some volunteer or someone who had retired a while back. We need to professionalize community health workers so that messaging and engagement with the community is based on an obligation that a worker has rather than just volunteerism, which often can be a gap in the health, in the system for health in a country. So we need a workforce of the right people, the right professionals, given the right tools and deployed to the right places when necessary. The third pillar is we need to own the tools that we use for response. We should never go back to the space we were during the pandemic where we didn't have masks, we didn't have sanitizers, because these were largely being imported from elsewhere before the pandemic. We need to ensure that we expand our local manufacturing of all the health products that we need. However sophisticated they may be, like vaccines, or however simple they may be, like masks and gloves and the different types of PPEs that we use during disease threats and health emergencies. We must own the tools that we use for our health security activities. Fourth pillar is domestic investment. We should not have a situation where health security matters are reliant on donations and grants from elsewhere, while we have enough in a country to be able to invest appropriately in the health sector. This mobilization of local resources is not just money, and money is important, there's no doubt, but we must mobilize human resources. Where are those individuals who are willing to participate in and be part of preventive and responsive activities when it comes to health security matters? Where is the technical expertise? And very often, a country has all the expertise you need. It is just that it is placed in different institutions, whether public or private, and they're not made available when you need them. And we saw during the COVID-19 pandemic how, working with the private sector, we were able to access in the early days very sophisticated machinery for pathogen genomics, for example. And with the time, of course, we built the public sector's capacity. But in the beginning, we used every technical capacity that was there on the continent. That's why we were a lot more successful than some people had predicted. So domestic investment, human, technical, financial, is important from both the public and the private sectors, and that is the fourth pillar. Fifth pillar is we know that there's a lot that we need to do, but we are also appreciative that we cannot do it alone. So respectful and action-oriented partnerships is key to implementation of the new public health order. And when we say respectful, we mean respectful of the priorities of the continent, of the community that we are talking about. Action-oriented means that it must produce results. We shouldn't have partnerships that are there in perpetuity. You know, nice, beautiful 4x4 wheel drive vehicles going into the community to pick a little data, you come back, the interventions are weak, that particular public health problem is not addressed, yet there are institutions that are being supported from elsewhere. We must insist that these partnerships produce results so that the community, the country, the region, the continent can be able to sustainably address its problems. These are important for our schools of public health to reflect on how they can be able to act not differently, but more efficiently. And here are my proposals on what this local role for our schools of public health are concerned where health security is being discussed. One is local evidence. Where is that evidence that for example, that COVID is transmitted by air? And I'm not saying it is, I'm just saying, where's that evidence? Where are our experts to be able to produce this evidence? Where is that evidence that some of the local products that were being projected to cause, to treat COVID, where was the research done? Where's the evidence? It's us here on the continent, in this country, who should be doing this. And we have a lot of these products out there. Who's doing research on them? Who is packaging them in a way that is going to be safe for the communities to use? And we need to do this across the continent. And our schools of public health, You are the custodians of evidence generation across the continent, and you should be leading the charge on getting our indigenous knowledge to be translated into actual products that our populations and beyond can be able to use. If we don't do this, our indigenous knowledge is going to get lost because our old people and the knowledgeable people are also not staying with us forever. So where is the role of the schools of public health in ensuring that this indigenous knowledge is generating good local evidence and we are translating it into products that we can be able to use? Third is capacity building. How are you building the capacity of our experts? We found the training being done in 1950, or have we changed the way in which we are training? Are we still training the same experts, or have we adjusted it based on the realities on the ground? Are we tracking to see that those that we are training are actually making a difference in the communities, and so we continue to train more? Or are we training because the curriculum is in place and cadre X and cadre Y are part of the universities or the School of Public Health list of those that need to be trained? Are we adjusting the content of what we are training? And I'm challenging my colleagues who happen to be lecturers. Are we using the same knowledge that we used on them 5, 10 years back? Or have we changed and adjusted that? We need to build the capacity of relevant expertise and cadres based on contemporary need, contemporary challenges, and possible contemporary solutions. Fourth is our schools of public health must be where the pool of expertise is. When we are looking for experts to design a particular strategy, we shouldn't be looking for experts from outside of the country or outside of the continent. We should be using experts that are local. But those experts need to be not only available, they need to be able to deliver on time. And that's a story of another day. When we were looking for experts during the pandemic, the rate of response of some of our colleagues on the continent was quite disappointing, and we ended up using experts from elsewhere. So when we are building this pool of experts to support our policy development, to support our implementation of policy, to review the policies that we are implementing, we need to ensure that these pool of experts are accessible. They are also well exposed to the areas of expertise that we want them to work in. Fifth is the setting of priorities. When you, as an expert at the School of Public Health, whether it is a lecturer, senior, professor, or it is the students, and by the way, we have very, very good expertise at the student level, whether it is master's or PhD, indeed even undergraduates, who can be part of building the expertise within a school where priorities are going to be set. That means the resources that we have in building our priorities are focused on what is truly a priority at country level, at community level, so that the priorities are not being set by someone who doesn't know the context. The priorities are being set by those who know the local context. And this is a very key role for our schools of public health to expand. And finally, is building centers of excellence. When we have experts, let's train them and refine their expertise. Let's use them so that they truly know their trade, they truly know their areas. And then we build an institution that can be a center of excellence, not just for a country, but also for a region and the continent, and eventually globally. That is how many schools out there have built their name. Now, instead of struggling for us to enter those schools out there, let us build our own, because we have the capacity to be able to build our centers of excellence. And I say that because for the last 4.5 years, when I was working with Africa CDC, we have gone around this continent and we know we have experts. We know we have institutions that can be able to be turned into centers of excellence. We know that we have policymakers who are willing to invest in this area. What we need to do is to tie all that together into one package that we can be able to put resources behind and deliver in a very good and efficient way. Finally, let me talk about how we can influence as schools of public health, how we can influence the work that we do out there. Documentation. We are very good at chasing work, but we are very poor at documenting what we have done. If you search today, and I challenge any of you to go out, pick a topic that you know the best and search for it, attach Kenya or Tanzania or Burkina Faso, whichever country you come from, or attach Africa to it. And you will see that the list of documented, peer-reviewed writing out there, whether it is papers, it is books, they are largely from outside of the continent. This is not good for the continent. It's not good for a community that your documentation is in the hands of others. We need our schools of public health to be the glue, if you want, that brings together knowledge that is local, that documents the knowledge, whether it is in writing or as a podcast or as videos. You need to do that actively so that knowledge can be able to be passed down the chain in an organized manner. Secondly is research, and relevant research, and I think I've spoken a little bit about this already. We need to research on what is relevant for us in our own community. We need to research on what is contemporary, are the contemporary problems that we are facing. And the research needs to be done when the issue is still hot. An example is during the Ebola outbreak in Uganda 2 years back. We had a delay in delivery of the trial level vaccines. And by the time the vaccines were delivered, the outbreak had been brought under control. And so testing it at field level became a challenge. This means that those who owned the product and wanted to come and do clinical trials, 3, which is also research anyway, they delayed. They did not understand our context. If it was us doing it, then it would have been a lot faster. So let's ask those relevant questions in the relevant time and answer them through good research, which schools of public health should be able to spearhead. Third is capacity. Let's train, retain, and then retrain experts. That way they stay. I don't want to go into the debate of remuneration because that's a little bit of a hot topic right now in Kenya. But there is no way you will be able to build your expertise if you don't train well. There is no way you'll be able to build your visibility, your name, if you don't retain the expertise. And there is no way you'll be able to continue being ahead if you don't retrain the experts with contemporary knowledge. Fourth is expertise. We had said we must build a local pool of experts, not just your friends. Experts are experts, whether you like them or you don't like them, that's another matter. But let's build experts, having a roster of some sort, having a platform where we can be able to have all our experts and we can access them easily is important. And that can start within a school of public health. That can start within a country. It can start within a region before it expands to the whole continent. Building expertise and local pool of experts is what will translate into a center of excellence, a specialized unit within the institution, or the institution itself becoming specialized in something. I don't see any reason why we don't have centers of excellence for malaria control, for cholera control, for Ebola control, for the Marburg virus control. Those are our problems on the continent. Yet we hear when experts are being looked for some of these things, it will be non-African experts. It is not good for us as schools of public health if we do not build our own centers of excellence. Finally, and something that is very poorly handled across the continent today is mentoring. Who is holding the hands of the younger professionals? How have we designed our succession so that when we get a little bit older, others are stepping into that space and providing the expertise without a break? How are we building that around a team? It cannot be only Ahmed all the time. It can't be Oguel all the time. There must be others. whose hands I have held and are stepping into the space and are also providing the clear expertise that is required when it comes to solving our health security issues. If we don't do that, then the visitor who came to Kilifi and was there as a resident researcher for 6 weeks will go away and will be an expert in malaria control, rather than you, who's lived with malaria from the time you were born to now that you're 65 years old. You cannot be called an expert because you keep everything to yourself. And I challenge my colleagues who are senior that let's hold the hands of the younger generation to make sure that we get a succession plan in place. I'm sharing this book not just because I am an author, but as a challenge to us. Where are the books that we are writing? Where is the expertise that we are translating into something that others can be able to sit, read, understand, criticize, adapt, and implement? And I've searched for books written on the continent. There are not many. There are not many. We need, and I challenge you, Pam, and your colleagues at the school. If there are challenges of resources, please come. We will talk about that. Let's write books about what's happening on the continent. Let's write books about what's happening within our communities here in the country. Let's write books that others can be able to follow and improve on when their time for leadership actually comes. African schools of public health must mobilize their expertise and their networks. That's the only way they can influence the health security agenda on the continent. We know there is the African Schools of Public Health Association. It needs to do more in terms of bringing on board the schools of public health. Today, by the way, if you ask me how many schools of public health are there on the continent, I don't know. I have searched, my team have searched. There is nobody who knows how many schools of public health we have. Now, that is a thesis that one of the master's students could be able to do. And I'm happy to support that kind of individual if that is going to be a key objective of their work, because it is information we need. We don't have a clear idea of the experts within the largest public health space. How many do we have? When it comes to those who are teaching at schools of public health. If we don't know the numbers of schools, then we can't tell what the number of our lecturers or tutors are. We need to do that. If we don't do it, then we will be failing in our responsibilities of ensuring that we are providing guidance to those who will come after us. I end by taking us back to this slide, the areas of influence that our schools of public health may be able to work on, improve on, and deliver, not just for the continent, but for health security and for public health in general. Thank you very much for your ears and time. And back to you, Pam, the moderator. Thank you.
Mm-hmm. Thank you so much, Dr. Ogwell, for that enlightening presentation. Thank you for the challenge about the schools of public health and the roles that we are playing, and most importantly, the publications that is out there, documentation, which is, I agree with you, it's a challenge in terms of our people not being able, our colleagues not being able to publish, write books, publish what they have done, irrespective of the fact that we do a lot of work, but it's not just out there. It's not out there for people to read and refer to it. Yeah, so I would like to open the floor for any questions or comments. Is there anyone who has a burning question? Dr. Ogwell had indicated to me earlier that he has, he only has time up to 3:15. Is that still the case, Dr. Ogwell?
Yes, absolutely. I'm joining another meeting at 3:15. So if I can end at 3:14, it's time to click the other link. I'll appreciate that.
Okay. So I would If you have a question, I think you can raise up your hand, and I can also check what is on the chat. I'm looking for any presentation, but I'll also just read some of the comments that we have. Anonymous says, great presentation. Okay, can I see this? Where is the place for AI in public health? We need to grab the prevention promotive health paradigm shift in Kenya and champion the use of AI to reach our clients before they become patients. Dr. Kibayas, public health specialists, yeah, a founder of the Public Health Society of Kenya. So there's one question there. There's a comment there on excellent overview and the nudge to do better in terms of public health on the continent. Harrison Kipsang says that I believe schools of public health generate a lot of evidence through research, especially research by students. What are the domestic platforms for publishing this local research? Writing books is key. This one of those books I have contributed, Global Health Informatics. Okay, so there's a book on global health informatics, principles of e-health and m-health to improve quality of care, Cambridge. Yeah, so there's a colleague there, Linus, who is saying that he has also published some books that you can also refer to. Then Mulimba says that as a recent graduate in global health, breaking into the field with my previous experience as a medical doctor has been a hindrance. Many organizations prefer experience within. How do we use medical experience as a boost? I know experience is also always an issue when you're applying for positions. Eloquent and precise information about schools of public health. A comment from Crescencia Nekesa. How aware are our African leaders of the need to invest in schools of public health and centers of excellence? That is something to consider in terms of resources.
Pam, maybe we can tackle one.
So maybe, yeah, you could address one or two. Some of them are comments and some of them are questions. You can respond to one or two.
Yes. So maybe let's start with the AI question. And I want to combine this with a question on One Health. I think I see another one down there. So in as far as AI is concerned, particularly in public health, if we are not doing it, then we are doing a disservice to public health. The reason being that there are many AI tools that make our practice of public health easier, faster, and more accurate. So AI is an absolute necessity for our schools of public health and our schools of digital, whatever it is, to come together and design something. We know also that there are many young people who are already developing their own tools that can be able to make our life a lot easier within the practice of public health, which I would like to link to the issue of One Health, animal, environment, etc. We cannot be able to practice good public health unless and until we use the One Health approach. Today, 85% of our outbreaks are zoonotic in as far as source is concerned. So it means that we cannot be successful protecting the human being unless we protected the environment, we protected the birds and the animals at the same time, and we've secured their health so that ours is also in the same light protected. So the One Health approach is not just essential, but it is mandatory for us to be able to succeed. And I'll not name the country, but 3 years ago, it was very disappointing. I went to a country where the School of Vet Sciences had the capacity for genomics, and they were actually sequencing pathogens that were related to animals. That same country did not have the capacity when it came to human disease genomics. And the two schools, the one for vet and the one for human health, were not working together. In fact, when it was time to do the sequences of COVID, they were going to a neighboring country, and yet the School of Vet had that capacity. Of course, we fixed the problem, but it tells you that we are not engaging with our colleagues in animal, bird, and environmental health as much as we should. And that's, again, my challenge to the School of Public Health, to the schools of public health, that we need to cross that divide, particularly here on the continent of Africa. Then thirdly, is domestic platforms for publishing local research. For me, I would not define platforms for publishing as domestic and international. I will just say use the platforms that are most accessible to you. And these days we have very specialized platforms and journals. So depending on what you want to publish, go out there and seek, whether it is international or local. Of course, local is always better because it is building a name, but publish where it is easiest for you to publish based on the contacts that you have. But it would be very nice for us to use our local journals first, of course, before we go outside. I think we've seen the writing of books, and I really encourage that we write, not just papers and newspaper articles for those who are leaning towards that, but also books, because it trains us to be good at passing information, and it is a source for our students to have something that is contextual in nature, something local for them to be able to use. Medical experience as a boost. Public health is beyond medical experience. So those of us who started in health sciences, I don't think that you own public health. Decisions in public health are being made by those folks who are never in health sciences. And we need to ensure that our influence within the public health space is commensurate with our passion for it and our contribution to it, not just because we happen to have passed through health sciences, our basic education. Public health cuts across so many different areas of expertise. About the proportions, no, it was never designed to add up to 100%. It was always designed to be the effort of the School of Public Health, where 75% effort in training, all those things mix, 50% in research, 25% in influencing policy and priority setting. It is not designed to be 100%, but it is designed to be what the school should aim for in as far as effort is concerned. Because within capacity building, the 75%, there'll be a lot of research going on. There'll also be a lot of priority setting activities that are going on, but it is just to show you the importance of those three very big pillars for a School of Public Health to reflect on. And that is from Ogwell. You can adjust it, but in my view and the little experience that I have, these three are the most key for a School of Public Health to be able to succeed and have a name out there in a balanced way. How aware are our African leaders to the need to invest? Leaders change very rapidly. Most politicians have a half-life of 5 years. I don't know, have a life of 5 years, so their half-life is 2 to 3 years. Let's make sure that we engage with them regularly so that whether there's a change in administrations or not, we are always there to provide what information that the politicians will need, the policymakers will need. That's where our local evidence becomes important. Back to you, Pam.
Yeah, so thank you so much, Dr. Guel. There's one interesting comment here from, I think, one of our younger doctors asking, how did you shift from dental practice to public health, Dr. Guel? How did you shift? Then I think the other areas where we can, questions which I have seen, just compiling a few of them, is that this is a comment how we can reach policymakers with this presentation. It's a very exciting presentation and it's broad. So any ideas on how we can reach policymakers with this presentation? And then how can we tap into the private sector to drive the agenda for public health? Yeah, considering that most of the interventions you'll find most of the funding you'll find going into the public sector. How do we tap into the private sector? So another comment was about KEMRI and APHRC, if there's a way they can have a collaboration with schools of public health. That is a general comment from one of the team members. Yeah, so it's a good comment, trying to see how schools of public health can also reach out to these organizations that are already existing and how we can collaborate. And then finally, there was one on Harrison is asking if there are any plans to build a vaccine manufacturing plant in Africa. Any updates on that?
Okay.
So can we handle those?
Yes, no, let's handle those quickly because
Yes,
it's
time, yeah.
7 minutes to my time. So first is how did I shift from starting from dental oral health to go into, there's really no path. It is your interest. Many of us start off doing clinical work, and those that end up in public health by design then grow into it. Don't fall into public health by accident. Do it by design. And then you take a path. And there are many paths in public health. There are those who want to do research, those who want to teach, those who want to do policy making, and then there are those who want to go into the international space. So there are paths that allow you to be able to grow into the area of interest that you have. Doesn't matter where you start. It's just your interest that is going to take you there. How to access policymakers. This is a local issue, and I hope that our colleagues locally can go to work on this. But for me, the most direct thing is engagement, engagement, engagement. Our politicians, our policymakers are human beings. You go to them with stories that are not making sense, they dismiss you. You go to them with ideas that are well thought through, well cooked, they will listen to you. And persistence has always been the mother of success for me. We must be persistent and use all the networks and the connections that we have to reach the policymakers. Private sector, very key. We saw with the private sector that when you touch on their interests, they wake up and they come and they provide that support. So it is an approach issue. How are we interesting the private sector to come and work within the public health space? There are many ideas and we don't have enough time for that today, but the private sector is key to opening up that extra stream of resource allocation that we need for the work that we must do within the public health sector. Vaccines manufacturing is continuing. A lot of interest. There are countries, I don't want to name, I'll not say it's a full list, but Egypt, Algeria, Morocco, Senegal, Ghana, Nigeria, Kenya, South Africa, Ethiopia are doing a lot. There's one that I forget, can't remember which one, there's supposed to be 10, that are doing a lot in as far as building up human vaccine manufacturing on the continent is concerned. It is a huge investment. It is not cheap, and it requires long-term investment and thinking. It requires working very closely with the private sector. It requires working very closely with the research community because you want to be able to have a product that you own from scratch all the way to the product, not to wait for to borrow intellectual property and technology transfer from others. So vaccine manufacturing is continuing across the continent, and we should be able to see fruits by early next year, when some of the facilities begin to actually produce products that are going to go out into the market. The challenges are many, but we see the commitment has been really, really good. And as a parting shot, the Palm, what I would say to us within the public health space is that we don't support each other enough, and we need to be doing that as actively as possible. Mentoring is the way to grow your ideas. Mentoring is the way to secure your legacy. Mentoring is the way to ensure that the next generation are part of today's solutions. It's been a pleasure to speak with colleagues. I really, really appreciate the opportunity. Back to you, Bob.
Okay, thank you so much, Dr. Guel. And I think we are almost coming to the end of this webinar because of time. The presentation has been enlightening, and at least those of us who don't have so much information about health security and the changing health security architecture, we've come to learn about what health security is and some of the key components of a health security plan. So I think moving forward, it's a challenge. It's a challenge that you've put to us in terms of publications, in terms of mentorship, in terms of creating partnerships. And I think it will also be important to see how we can build up these partnerships between the different schools of public health in the region, so that we are able to share knowledge, share experiences, share student exchange and scholarly exchange programs within the region, and just to see how and learn from each other. Because you might find that one region is more has better capacity than one school, and one school is able to learn from one another instead of waiting to learn from other regions, which sometimes it's not really context specific, and it becomes a challenge when it comes to turning that research that you've done into practice. So thank you so much, and I hope this is just the beginning of the discussion. We are going to keep discussing, Dr. Guel and other colleagues, you're going to keep discussing more and see how we can move forward and contribute positively to the development of our nations within the region. Thank you so much.
Thank you.
Okay.